Hello to you all, and thank you very much for the invitation to join your meeting today. I'm very conscious that I would love to be there with you and unfortunately just can't. But myself and Michelle are really delighted with the opportunity to present to you on the proof of concept testing for a community virtual ward. This is a brief presentation on testing an integrated nurse-led service using the community virtual ward model to deliver acute care in the community setting. Much of the work to date on behalf of the Chief Nursing Office was completed by Dr. Claire Lewis, who I'm delighted to say has gone back to work in the area of integration and innovation in the HSC. I'm very conscious that most of you will fulfil roles from directors, assistant directors and public health nurses today, and I'm really pleased to hear that you are interested in this concept of care delivery. The proof of concept test that we did on this obviously is about moving very acute patients out into the community setting to deliver care and using both the community and the acute resources. The model itself is flexible, so can be adapted, and I'd be very interested in your feedback after the presentation today. So thank you for your time. A community virtual ward is a method of delivering a combination of acute and community nursing care interventions in the patient's home. The community virtual ward has two aims. One is admission avoidance, and two, to support patients leaving hospital and to return home. The community virtual ward operates across community and acute services with shared processes of care including referral, information, care planning, care delivery and evaluation. Care takes place in the community setting, mostly in the person's home, and the beds are virtual, so they're not physically in the hospital setting. You will see here on the slides in box 1 that the process begins with both community and the hospital. So patients are assessed for suitability of a community virtual ward setting. We're ensuring that the patient needs are met, meeting the criteria for admission to a community virtual ward. And it's important that the plan of care and outcomes identified are inclusive of the patient needs. The patients are admitted then and discharged from the community virtual ward. Care is delivered in the home, and you'll see this in the second box. There is assessment a need of care of the patient. The plan of care is developed with inclusion of the patient. There's remote technology to support the delivery of care, which is appropriate for each patient. There will be implementation of interventions appropriate to the patient need, and there's evaluation of care outcomes for each patient individually. The third box then shows that how do we know our outcomes have been achieved? That we will see evidence of symptom improvement for the patient, improved quality of life for the patient, improvements in self-efficacy, admission avoidance and reduced hospital readmissions over a period of time for the patients in the community virtual ward. So the unique value proposition of a community virtual ward. So it modernises integration to supporting the shift of care into the community, and it manages full episodes of care for patients and includes acute and community nursing services working together. It provides clear and robust governance structures to ensure clarity on authority, accountability and decision making. Provides a model of care for mobility of nursing services, delivered shared care through both hospital and community nurses and midwives. It contributes to bridging the gap between access and coverage with the community as a central point of contact. And of course it enables economic value of nursing and midwifery to work to the top of their licence. The community virtual ward is designed to drive implementation of the sorted care strategy through reorientation of nursing and midwifery care. The implementation used a scientific approach, so we used objective data collected through remote technology. We used screening tools such as the quality of life indicators, self-efficacy, symptoms, functional capacity and dependency levels. We correlated the impact of the model with patient-related outcome measures. Important to this, and Michelle will talk to you a little bit about this later on, we used user experience. So we got feedback from clinicians, patients and administrative staff involved in the whole process. And the outcome and process measures then, numbers supported at home, numbers of patients that were supported at home versus hospital and ED. We used a self-efficacy, again, quality of life indicators, patient satisfactory surveys, and we used direct versus indirect care, a number of contacts that we had with the patients, the intervention strategies, the out-of-hours care and the level of self-management in order to implement this model of care. You can see then from the planning involved testing of a proof of concept. So using the objective data and the validated screening tools, we used mapped processes, workflows and resources to define the model of care. Looking at the resources to deliver the care and metrics to measure the impact. If you don't measure the care delivered, you can't manage the service. An agreed governance structure was also required to provide the service and ensure that the deliverables were realistic. And this was a significant piece of work because it had never been done before in terms of having that agreed governance structure over community and acute nursing services. The proof of concept then was carried out on patients with chronic respiratory disease, which was timely as we were in the period of the COVID-19 pandemic. And the community virtual ward model was designed as flexible and can be delivered to a range of acute patients in the community setting, but obviously that will require further testing. The remote technology that we used in order to deliver the care through the community virtual ward included both low and high technology. This included portals for patients to record information. It also included a portal for staff to record and access the data in real time. Professionals can access the information and data provided and support relevant treatment as well as liaise with each other. So it certainly created a continuum of communication between the patient and all of the clinicians that were involved in the care. So the community virtual ward proof of concept then. The proof of concept of community virtual ward pathways. So the GP refers the patient and the governance is supported then by the acute hospital and the community health organisation. Care is delivered by the community intervention teams, which is what we did for the proof of concept, and supported by advanced nurse practitioners. The care is delivered using a combination of remote monitoring devices and direct care. And the ANP designed the plan of care in conjunction with the community intervention team. And the patients were reviewed remotely using video, telephone, or they were directly seen in their home. The objective data, which was the symptoms and response to treatment, were evaluated to determine discharge, data and referral onto other services if required. Finally then, after a period of monitoring and intervention, patients were discharged back to the GP if suitable. I'm going to let Michelle give you the feedback that we got from the patients and from the clinicians now, just to give you a sense of what the proof of concept showed for us.
Thank you, Rachel, and everybody, I'm delighted to be with you. So when we looked at the feedback from patients, we categorised it into 4 themes. One was self-management. All patients felt that they'd learned something new about their condition and had more understanding of how to manage when they had an exacerbation. The devices also allowed them to understand their symptoms more. They increased their competency in inhaler use, and now they felt they knew what to do when they became breathless. Under the theme of partnership and shared care, patients felt that they were part of the plan of care, and they also reported that their families were better able to understand their condition and how to support them. In relation to discharge, all reported that they would like this resource when leaving hospital, and if they had been aware of the resource, they would have left hospital earlier. And all reported they would use this service again, as it would reduce their need for hospital admission. In relation to technology, all patients felt that the access to remote technology helped with that anxiety and made them confident in managing their own symptoms and understanding their condition and how it could be managed. And some even felt that they learned new skills in accessing technology. So when we looked at the information that we received from the admin and professional staff, they shared the following. There was a greater level of integration and improved effectiveness and efficiency in the communication. The shared process of care and access to timely information across the acute and community services meant that everyone knew what everyone else was doing in terms of care planning and discharge planning. The level of engagement was due to the continuity of care and shared interventions that were targeted to the needs of the patient, enabling more nurse-to-nurse communication across the spectrum of care. There was timely access to diagnostics as required. There was a central point of contact in the community to support the GPs and access to specialist general nurse services to reduce the need for ED admissions. The supportive care was delivered by the community intervention team, and they reported effectiveness and efficiencies in the programme of care that was planned by the AMP who worked in the hospital. And this also supported nurses in understanding each other's roles and skills and to work across the services to provide care. There was upskilling of the community nurses' knowledge and skills in managing chronic disease and the understanding of the acute hospital and how it was improved, and vice versa. Nurses, as we know, are recognised as long-time learners, and this supports education and upskilling of all the nurses involved. It also supported nurses to work at the top of their licence. Thank you, and I'll now hand you back to Rachel.
Thanks to Michelle for giving us that feedback from the clinician's perspective and most importantly from the patient's perspective. So I'm going to talk to you now about why it worked. So bearing in mind the feedback that we've just heard, the proof of concept worked because it was an integrated model of care. There was a collaborative assessment and care planning process, technology-enabled care, video-enabled assessments with remote monitoring using remote monitoring devices. Importantly was the integrated transitions of care across community and acute services through the community virtual ward with enhanced discharge planning, all led by nursing and midwifery. Also, there was the integrated sharing of information between professionals, which has sometimes stopped us from being very progressive in terms of patient pathways in the past. It also worked because it has proven itself in a short time to be a very economic method to deliver care. And if you look here at a summary of the cost of the community virtual ward per day for a patient was approximately €88, and that was inclusive of the remote monitoring platform, while the cost of care as a comparison in the acute hospital setting per day is €820. Now obviously that needs to be tested on a longer and wider scale, but as a proof of concept it certainly is delivering in terms of economics. It is in line with the policy and strategy direction for health services, which is Sláinte Care. So if you look at the policy and strategy direction of Sláinte Care, the model of care is an enhanced nursing model, and it is an enhanced midwifery model of care delivery directly into the community and supporting the enhanced community care approach. It supports integration because it's underpinned by strong governance which facilitates integration of nursing and midwifery services and the development of bespoke care for different populations of patients. It is also enabling e-health. So it is enabling technology to improve service delivery, patient engagement, patient access and choice for patients. So all in all, it is very supportive, encompassing a lot of the direction of travel that is underpinned by Sláinte Care. So Community Virtual Ward also encompasses some of the other nursing and midwifery policies that have been very successful in improving care, delivery and choice for patients. So it does take into account the policy on the development for graduate to advanced nursing and midwifery practice, the framework for safe staffing and skill mix, the National Nurse Midwife Medicinal Product Prescribing Guideline, and the Enhanced Nurse and Midwife Contract. In terms of further testing to inform the policy and strategy directions, we need to encourage this and get pilot testing across a number of different areas because it maximises the mobilisation of an integrated nursing and midwifery model to support enhanced community care. We provide the model architecture and infrastructure to deliver this, including governance, integration and digital healthcare. And we can deliver sustainable, digitally enabled model of care to support population healthcare needs and move away from the hospital-centric model through nursing and midwifery leadership. So the potential next steps then for us and what we're thinking about is that we need to map out the community virtual ward in the context of supporting the development and rollout of the enhanced community care model. We do need to engage in wider testing for different population groups such as older persons or patients with heart failure. Based on the current model, each site will require access to a community intervention team, planning to or have access to an advanced nurse practitioner, and this can be a candidate or a registered ANP, and that we need to be based in an acute hospital setting already delivering care or in a community setting delivering care in the community. and we then need the infrastructure to support out-of-hours pathway for escalation. And this is really important in terms of patient safety and making sure that the patients can remain in the community virtual ward. For each site, then, you can approximate that it would be 660 patients based on a 20-bedded community virtual ward with an average length of stay between 7 and 11 days, which is what we have shown. Access then to the community virtual ward is through the GPs or the acute hospital setting following an acute episode of care in that setting. The aim and objective of the community virtual ward then is to support the enhanced community care model, which is access to subacute care as an intermediate step to care in the community, and support challenged hospitals and the Sláinte Care Reform Programme. Thank you very much for listening. I hope that you enjoy your meeting, and we're very happy at any stage to be contacted in the Chief Nursing Office, and we hope that we'll be able to come with an update of our plans that we will encompass into next steps for testing of this community virtual ward. Thank you for your time.